Or at least supposed to every other day. Okay. And my father did it together. As he said. Well, we'll wait till 8:15.
This one was worse, so I left it. It was still like a little kind of bloody, so I was gonna cover it overnight, and then it's all good. I showered with gloves on, and I can't run. I was like.
That would be really bad. The IT guy that doesn't believe it. You were 3 weeks in school this week. Like, no, that's not how spring break. Oh my God. I mean, it is a big weekend.
Last night was awesome. I'm on the record. I'm like, Red Sox, all at once. Boom, boom.
Is the Celtics win?
Celtics won.
To the driveway and I see someone standing and
I rolled. Sam emailed that she smiled and not talk back.
not bad.
6 months? Yeah. Must be sitting up? No, not yet.
Please support. You can hold.
Cooper couldn't sit it. At 6 months, I remember going to this little thing in Brookline. What was that? It closed now.
I know what you're talking about,
They
yeah.
had
ISIS fraternity?
Yeah. That was before, like.
Well, anyway, then all the little baby girls are like this, and he's like this. like face planted, crying. And I was like, come on, you can do it, sit up. And he's like, he ended up doing everything else totally normal. He just was late to like physically holding his abdomen up. All the girls, it was all the girls that could sit up, and they were like,
Having a pediatric healthcare provider parent is a risk factor.
you're right.
Oh, medical checkup, like she doesn't walk, she doesn't talk, she doesn't do anything, and she's fine, she's fine. And sure enough, the next day, she walks, she talks, she does everything.
Yep.
And then she never stopped talking.
Yeah, exactly. I remember. Yeah, we were talking. And I was like, I would still babysit around, like, I mean, I could call her.
Well, that was like,
One day she was on, I knew she was on.
Layla.
Yeah, she understood everything,
She
and
was
I was
still
like,
there.
she knows what's going on. She's not hard of hearing. So, I wasn't going.
Oh, great, I'm excited.
My fiance's even more excited.
Yes.
I didn't even think of it.
Yeah.
You know.
Oh, Marianne and I have the same birthday.
Oh, on Friday?
Patrick.
I literally started there and moved my way up until I got there.
Sorry, Abby.
That's so rude.
That is so rude.
I know, right? What's your name?
All right, I'm gonna get more coffee and then we're gonna get going.
Yes, ma'am. Sam emailed that she has a funeral this morning, so she'll not be here.
Okay.
I might be Jen Draper's mom's funeral.
I was trying to find out where that was, I couldn't find
You know what, Jen posted it, I didn't look, she posted the obituary yesterday.
Okay.
Her mom died,
Yeah.
What's her mom's name?
I think she had cancer. Actually, she was sick, yeah. Jen said I was so blessed to be able to spend every day the last 9 months with her, so I think Jen took care of her, for the last.
Oh, she did?
I think so.
Yeah.
I think her not working kind of tied in well with the timing of it.
All right, everyone. Before we begin with the agenda, I wanted to very excitingly introduce Alyssa Gaudet, our new behavioral health therapist.
Welcome, Alyssa.
Wait, AG?
Huh?
AG.
Alyssa.
Yeah.
Gaudet, yeah, that's
Yeah,
right.
Annie
Another
Gray.
AG. Oh, that's gonna screw up the. Oh, we're gonna up to AG2 when I put it AG2. You'll see what I'll do. That's right. On the screen. Oh, that's right. Yes. We're gonna reach it.
No, we use the
I got
middle
it.
initial.
Oh, use the middle
That
initial.
is, I'll be AJ.
Oh, because you're gonna get married, right? Okay.
Oh,
When's the wedding?
November.
We're gonna start her with AJ then.
Yeah, you're right.
Okay.
But AJ comes to us from Children's Hospital. She works in the emergency room, working today. And we're hoping that she begins maybe August or September after credentialing all goes through.
So probably November.
Don't say that. Don't say that.
Where will you be? All over?
Between all three.
Yeah,
Okay.
we'll work all that out. That'll be a next step. She's, what's going to be a little unique about AJ's schedule, Alyssa's schedule is Alyssa will be tapping into weekend hours. So we're going to start to do that, and it's not going to be every weekend. She does have a life, but what it will look like is one Saturday and one Sunday a month, with a trade-off of one weekday on it during the week. And I know from personal experience that the weekend hours are very attractive to families. They will take them over the middle of the week craziness and all that. So we're looking forward to that.
Like a 9 to 12 type thing?
Yeah,
Or
9 to 12,
8:30
9
to
to
12.
whatever time you guys get out of there, something like that. But yeah, probably 9 to, I was thinking 9 to 30, like 6, maybe 6 actually on the weekends or something like that. So like if I get you like to 1:30 or something like that. What time do you usually get out of
That
there?
sounds about right.
Well,
That
yeah.
sound about right?
Yeah,
It varies on the
Weekend
season.
could be.
It's seasonal.
Right,
Yeah.
It's seasonal.
Yeah.
Could be though.
But summertime, what's your average summertime?
12:30.
Yeah.
Yeah, summertime, yeah.
Well, I don't know, every summer's different.
I don't think we'll have her by the summer, unfortunately.
No,
Maybe August,
right,
but,
that's true. That's
Uh,
true.
Well, that's great.
So, we're very excited to have her.
I think you can
and,
make an argument that it should be 2 or 2.
Yeah.
That's
Everybody's problems go away.
Everybody's problems go away this summer.
Amazing. Right?
I know.
So we're very excited, and you'll see her around. I'm going to be over the next few months doing some orientation with her, where she'll be going to the offices with me. We have an agenda, a list of things they just get used to, like where the key is for bathrooms and stuff like that. But you'll see her around because we'll spend an hour or two each at each place. So. Welcome.
Welcome. We'll keep everybody posted on, you know, the progress, you know how it goes with credentialing. It's a little lumpy, but we'll do our best. Yes, exactly. Well, I wanted to try to get an update on the travel clinic. We don't have Sam or Jonathan here, but I don't know, you know, some of the staff were a little bit confused about whether we were doing travel again. And I don't know if the nurses are, what are we at?
So I briefly told the charge nurses who briefly told their staff, but we're still waiting on those criteria from them to really be able to do it efficiently.
Yeah.
I know Erica Hirsch from the front desk sent me an epic message and was like, are we doing them? Because we're not really sure. So I said, well, we really haven't solidified anything yet. There are some providers willing to see patients, but we really have to get that policy in place.
Right, so I'll try to,
What is the part that we don't have yet?
I think it's the countries that
Staff that
feel comfortable with. I mean, is it, and I think the questions, that's what it was. It was the questions that they should be asking. And we had it before because we had it on a phone mailbox. So we really just need, I probably, if I think about it, come up with it. It was like, where are you going? Where are your stopovers? How long is your trip? I forget all the.
When are you going?
When you're going.
You call the week before.
Yeah, so.
Basically the family would call, they'd go to the voicemail, they leave a certain amount of information.
Right.
And then a nurse would take the
picks it up.
message and decide if that patient could be seen internally or would have to be referred.
Yes, so there's like a list of countries, I guess, that are supposedly easier to do than some of the more complicated ones, I don't know. So I'll have to chase, that was today, today's Tuesday. I'll have to chase Jonathan down today. Because he's in.
I mean, he did the template already,
He did the template.
so we have that
Okay, maybe it's on the
for the
template.
visit. No.
Oh, all right, let me just, okay, I'll chase him down, but, you know, maybe once we get all the pieces in place, and let's shoot for, you know, the end of the week.
Okay.
And, I'll send a message out to everyone and let's get it going.
Yeah.
The Pop Warner and
Travel
the other similar kinds of like cheerleading and things like that, how are you doing with that? Are you, it's probably more a staff question than a provider question, but are you getting any complaints or, you know, anybody hear anything? You did send the email out that, you know, stated that we were going to use the health form, which is on my agenda. But that's going to be important in terms of the health form. And I did get some feedback from the front desk. We're not getting, we're still, you know, it's better, but we're not doing that well in terms of getting that health form for patients when they're checking out. So, I don't know, we've got.
Can you explain what part isn't happening?
Well, they're not completed.
They're not completed. So we were shooting
So
for.
they said by the end of the day, a lot of them are, but not when the patient leaves.
Right, we were shooting for.
Can you be more specific as to what's not completed?
The form is not ready to
The
be
form
printed.
isn't ready to be printed.
Right, but where's I guess the point is, where's the gap? Is the gap that it hasn't been updated with the immunizations from this visit, or is the gap that the provider hasn't done a form with the waiting for that?
I did not ask that question.
Yeah, we don't.
It
know.
must be the provider, I would think, because once it's open, you can't close your note until it's been printed.
Right, but the question is,
Oh, maybe
if it's
they're-
not
So-
pended.
If it's
Right.
pended, you
But
got it.
they know how to update a pending form.
But
Mine fall down it.
lost this too, I thought.
No,
No,
if
the
it's
nurses-
pended, it just needs to be refreshed.
Right.
So either the nurse or the front desk could do it.
But I'm,
So is it a pended form that's stuck, or there's not even a form pended?
Can you ask the nurses,
Probably don't realize.
or the front desk, if mine aren't done? And then I will tell you what the problem
No,
is.
that's it.
Mine are done? Okay, well.
They do need it printed, because if they're not portal registered, it won't be there.
We just took overnight after
Right,
that.
they probably have no idea that's where they're at.
Yeah, if they are registered, it is, if it's sent.
So,
But if the
so
front
with
desk doesn't have a bunch
providers,
of print, then it basically hasn't been sent either.
how many providers finish the form and pen it before they leave the room?
right.
So then what's the problem?
No.
No, like if we're all doing it, where's the problem?
You're not all doing it.
You're not.
You're not all
There's a
doing
lot
it.
that gets sent. That don't need to be
And then
updated.
front desk can't access it.
Yeah.
Right?
So those ones the front desk never sees.
Well, if they don't need jobs, you can send it on the front.
I do it for them.
Sometimes they don't have any of them. Some of them just don't.
Let's try to have one conversation.
I guess I'm still not clear on where the problem is. If all the providers are saying that they do the form before they leave the room, where's the
Right,
issue?
right, because we're saying, we had 3 questions, ready at checkout, ready after checkout, not ready at all. And occasionally, ready after checkout, same day is mostly yes. So it looks like the day, at the time of checkout, it's not ready, but by the end of the day, it seems like it's
I
ready.
tell all my people, like, your
Right.
form is at the front desk.
Yeah,
Pick it up on your way out.
yeah,
So
well,
can you tell me what the front desk workflow is with this?
And then they'll look,
Not
and then
very
they'll look
good, they
and
do.
see if it's in the, ready, in the,
In the
letter.
letter.
review.
Well, who's not doing it?
well,
It's the expectation that we're
Then you have to
printing
name
them.
names.
Okay.
So, and if it's me,
All right.
I'm happy
I
to
have
do
named
that,
some
but
who are better than others.
my
have to
understanding
tell people
is
Yeah, I
that-
didn't wanna say, but, you know.
well, this is what I have, I'm gonna, okay, I'll be transparent, occasionally is ready to check out. Meredith, Catherine, Jen, hi. Jen, hi, Meredith, Catherine, Jen, hi. Most, no. So this is by person, okay, they're answering the question. So,
Surveyed by provider.
No, but what I'm saying is that there's a
Okay.
problem
No, no,
with
but
the
that's
system.
that.
Yeah.
this is the front desk staff, so Meredith is doing it occasionally, Catherine occasionally, Jen Hyde is under occasionally. And
Go to the portal.
most, no, all right.
What does
Then
that mean,
frequently, mostly, no, most of you know.
When they check
it's-
out.
It's not
Yeah,
ready,
The occasionally are the ones who are doing it well.
occasionally, right. No, frequently as
I'm
well.
literally doing everything.
Adam, Jonathan, Lisa. And then after checkout, then some are saying most of them, yes, they're doing it. I mean, you know, so some people are given specific names, others are just saying most of the time.
So do they ever interrupt us? Because I haven't been interrupted.
I think, no,
ever.
the policy is for them to interrupt the nurse.
Sometimes I don't, to be honest with you, like if there's a baby and the mom stays home and the
Yeah.
kid's not in daycare.
Oh,
Yeah.
oh, I,
Infant's not in daycare.
I don't see that.
Well, if they're going to the portal, A, if you finished it and sent it to the portal.
But it's fully
how do I send it to the portal?
Yeah.
When you hit send,
It goes to the
It
portal. Okay.
never goes to the front.
As long as they're,
Right,
So when I
maybe
hit
that's
When you
part of
hit
it.
send, it
Part of
should be doing both.
It should be
Print
doing
and-
both.
Only some of them.
okay.
Oh, but actually, you know what?
I've sent
Sometimes
people
my
now.
computer isn't where I am on that day, the laptop doesn't actually print it.
You know, I think we should do a very, like, if you guys could just, you know, be aware and like be, what's the word I want? You know, yeah, just try for, like, let's say for a week, we're like super focused on it. And maybe we'll do a very focused,
But Steve, I do
doing
what the expectation is, whether we're printing or not. I haven't been printing mine because I assume there's labs and there's immunizations and so forth, so I've been. Pending it?
Pending.
Well, I say send them, I do the little green arrow thing and I refresh it and then I usually put send on closing the counter, which maybe is the wrong. That would be at the end of the day when you sign it.
Or whenever.
But you would still have to it would still have, well, if you pend it, it basically sends the message that you're done, and then once the nurses input their data, they refresh and send.
pending.
Do the nurses automatically
have to know that they're gonna do that? Like,
Yes,
yeah,
they know that.
They know that.
They do.
Yeah.
They know that.
Okay.
They know that.
That
Because
makes
sometimes
Sometimes I'll tell them, you're gonna send it, right, but then,
Because at the end of the day, when you go to sign,
Yeah, it's
you're
not
putting notes
happening.
say that this is
so then
never.
that makes
Yeah,
it
I
on the
get
nurse.
this.
So that
I
needs
get
to come on the
it.
nurse, so
Yeah,
we're,
okay.
okay, so we
Yeah.
definitely need to do a
I-
workflow
Yeah,
And-
analysis.
and on those ones, I think I just tell them, I usually touch base with the nurse and say,
Would it be
it needs to
better,
be updated and set when you get the shots. Yeah.
would it be better
Usually what?
if this workflow went directly to the front desk? We skipped the nurses and we skipped us, so our update and print,
But what if
and
the,
just to unify it.
but what if the immunizations aren't?
Right, or if a lab is still pending or
They
something.
wouldn't know, like if
Yeah.
they, if it's an
Yeah.
11-year-old
Immunizations
checkup,
aren't updated.
but they have to be, so the nurse gives the 11-year-old shots
Yeah.
and then goes and scans them. And if the family walks right out of the room and the
Okay.
nurse hasn't beat each of the 4 things before,
To be fair, they should be scanning it before they give a shot.
They should.
That's-
they should be?
Yes,
Why do they
because
That's
if
why
they-
we're not-
If they don't scan it first, they could give the wrong thing.
Right.
What they scan has to match.
But do
what
they
order.
scan it and then they put in where after they give it? Because
No,
what if
they
they scan
usually-
it, go in and the patient's like, actually, we changed our mind.
Well, that's probably more rare, but most nurses have like their thing, I always give G-tap and
Right.
right, and like they put it in.
So
They
once
scan it
it's
and say-
scanned,
Once it's scanned,
is
it's in
it,
there.
is it said it's administered or is there a separate button that
It's
says?
said it's administered, like
Oh,
Marissa
then
gave my
so
shots.
once
It's
it's
scanned,
scanned,
it's
it's
scanned,
form
and
coming up.
form,
Yeah.
and I gave them, and I printed my form that's already there.
Oh,
But-
okay, so,
But
interesting.
maybe we shouldn't be printing them ever, and maybe the nurses shouldn't be printing them ever. And the front desk should be responsible for updating it and printing it. We pen it,
Pen
we
it.
fill it, and
That
we
would
pen
work
it.
sometimes.
So how do they know it's complete?
Cause it's
Yeah.
pending, cause we penned it.
So they'll send it.
No, but the
It would
nurses
still
have
need
to
to be
update it.
refreshed.
Right.
The nurse, why can't the front desk update it?
Yeah, they can.
We had a reason
You just
for
click on
not
the-
wanting them.
I'm just trying to
do it.
simplify
Yeah,
it,
that's
right
just-
now.
that's
We
if they're
don't want them
completing
to
the
make
actual
the form.
form, yeah.
We don't want them to
Which I don't-
generate a
I don't
form.
Right.
work,
Okay.
because I've had that.
But a
It does
pending
have
form,
work.
they can hit refresh and print.
So who would they go to if it didn't get pending?
The provider.
I think it should go right to the provider, because they're busy enough, just come to us and say, I don't have your form.
Yeah.
And I'm telling you, if you
Carol
get,
O'Keefe.
if your door gets knocked on enough times, the people will start completing it.
Yes.
It's annoying to get interrupted.
Yes.
I think it's very clear that this is our, we all agree, it's our
I
job to
think-
do it.
yeah.
Like, we know that.
I just thought there was a hiccup with the update of the IMS.
And actually, that might help this weird printer thing sometimes. Because depending on the day, my printer assignments are not always, usually when it's working right and I hit send, I'll get the printer choices.
Yeah, it's weird,
And I'll
sometimes
pick
you don't.
front desk printer, and if and then always front desk printer is sort of pre-selected, but I get the choices. But some days, I don't get a choice. And on those days, it goes to the one that's in my
Well,
print
when you're
profile, which is
logging
the
into
office.
Epic, you know how you just do return?
No, no.
But it changes, it
No,
changes
it,
now.
because I pick the office so that my medications will print in the office.
Gotcha.
But when I print the form, most of the time, on most days, I get a choice. And that's the
Oh,
same
I
when you
never
print the
did.
asthma form, because if you get the choice, then you can pick the color printer.
And I don't get the choice, I have to go to print options.
Right, so
Right,
I think
there's
that
enough
sometimes
variation with
it's
it.
quirky, like when
Do
we
you
log
think
in.
it's not a process? Like, is there something different about the time that it goes to
No,
one
it's
printer?
just some days,
So it's been my experience that if you, once you change the printer once for something, then where it goes next time is completely variable.
Really?
Right, so if I print out a if I'm in a different encounter and I print, it's just
No
definitely
rhyme, no
hiccup.
reason to it?
Definitely hiccup,
Yeah.
and I don't know what it is.
So sometimes you get to choose a local printer, other times it goes to default server job.
shred those, because I'm assuming that, okay. I don't need to do that.
Steve, say that
I
again?
would just want.
Sorry?
Say that again?
No, they're saying sometimes you can choose the local printer or one in the office, other times it goes to that, what they call the server printer,
The server.
based on what Epic is set at.
That's correct. It's not, so it seems most, the server printer is for like always the prescriptions,
Correct.
but the communications, you get a choice most days.
Most days.
But some days, that window doesn't pop up and there is no choice,
And it goes
and then
to
it's
that server.
printed somewhere, and it's usually
One
there.
of the server.
It's going to the portal.
All right.
Well, it always should be going to the portal. You're saying it doesn't.
Anyway,
But
in
it
point of
seems
fact,
like
if we
when
don't
they're
know where it's going,
Yeah.
that's a
It seems like
problem.
when they're active in the portal, it sends, it doesn't print, it just goes to the portal.
But I guess my point is, if this is like a hard thing to sort out, Adam's idea about having the front desk be consistently doing it would mean at least they know where it's coming
Yeah,
out.
I just think from a workflow perspective, consistency is probably good.
Yes.
And if
Yes.
it's very clear that we aren't supposed to print it, we are supposed to pen it, and the front desk doesn't have to, and the nurses don't have to do anything but enter the labs and the immunizations, which is their job anyway, and the front desk, it will also enhance people checking out, right, although I think they probably do a pretty good job of that anyway these days, so it will make them stop and check out. And the
Yeah,
front
I like
desk-
that,
And the
'cause I
front
keep-
desk can be in charge of it.
I'm always bothering the nurses, reminding them, like, I'm pending the form, remember to print it. But I never quite know, like, do I need to be telling? Yeah.
If they penned it, can they still close the note? Let's say,
Can we try
let's say.
that?
I think we should try.
So
it.
if the front desk
Yeah.
delays printing it
Yeah.
for some time, you won't be able to close the
Yeah.
note.
We'll
We
yeah.
can't close the note now. I'm dummy printing I'm dummy printing 4/5 of my immunization forms.
Yeah, no one ever.
Because I can't close the note, the patient's been gone for 20 minutes.
Oh.
Right.
So I
you
print,
can't
so I
close.
printed to
Yeah.
a fake printer.
So
I
it
don't
might
know.
not be a bad option, let the girls go through them and just, so then but you guys didn't have to follow up and close the note thereafter.
No, once
Well, we
once
can't-
we've penned it,
Yeah.
print it, our note will be closed.
No, I know, but they may not be printing it for quite some time. They may.
From PRN medicines showing up, like if we cleared, a lot of like Tylenol, ibuprofen in my med list that I don't want in there. And it says the nurse reviewed it, but it doesn't
Oh,
really
that's
look like it's
actually
updated.
that, I can talk separately with you, Amanda. I've gone nurse by nurse to teach
Yeah,
them
it's
how to.
Okay.
They don't understand how to do the med check.
Yeah, the meds come in
Okay.
terribly.
So if you have a med that has expired because it's been 30 days, an ADHD med,
Yeah.
but they take it only on, let's say, school days, and so they have more pills, and so your prescription was printed 30 days ago or whatever, it will say expired. They won't have an option of checking it as taken, which is why it doesn't ever show up as a med that they're taking. They have to edit the end date. It's a quick click in the med reconciliation thing, but they don't, the people I've told have been like, oh my gosh, I never knew why I couldn't check it. There was like this light bulb.
So what, then the
Hopefully
med
they'll-
isn't pulling as if they're actually on it?
There's no option, it's there under the med list, but they can't press check, so they just leave it blank and they review it and they close the thing.
Yeah.
Is that why people?
Because sometimes, a lot of times I feel like my med list is not.
Sometimes I just prefer
The
to
code
text it because
right. All their
you have to
behavioral
like
health
make
meds,
it,
all the
and
ADHD
if when you make a
meds.
change, the discontinued ones pull in too. Okay.
So what should we do?
So I can show you, I'll show you on a,
And then I
on
will
a-
go over it with the nurses.
I'll show you on my first patient today.
Okay.
Sure, so,
Someone.
Awesome.
It's easy.
Okay.
So
But
what
it's
are,
like
what,
just a
so
refresher.
along that line, if we have a minute, what are people doing for medications in their notes? Because it's been my experience from reviewing a lot of the nurse practitioner notes that the template says no outpatient prescription.
That's because they're,
But, no, but like, I'm reading notes where it says patient on flow, because I haven't found a
I leave
solution.
it, because if the med hasn't been, like, if the med reconciliation thing hasn't been done and I'm already busy and behind, I'm kind of like,
Do
you
you
know,
think
it's
they're
pulled in.
connected? Do you think
Yes.
they're connected?
Because the
No,
nurse
I
has
think
to
the
review
template's
it.
bad, right?
In order
Like-
to
But I think
like,
Carol's asking if we fix the other issue
Yeah.
we're talking
It'll
about, would
pull
it
in.
help the correct
Yes.
meds into
It
the
will pull in.
physical
Yeah.
form, will it correct also that
Yes.
link
So
in the
Amanda, you're up.
Yeah,
Because
it'll
it-
pull in all the asthma, so right now, if they
Yeah,
just
so it is
review
an
it, but
issue.
they don't press the check-in, or the taking rather, either because the
Yeah.
taking option isn't there, because it says expired or whatever,
Right.
then when we pull in problem list, medications, and allergies, which are the three things out of that box I
It's
usually
saying
do,
patient's not
it'll
on
say
it.
no outpatient medications.
But the
Which is not
asthma
good.
medication, if you ask a parent, are you taking Flovent, they're gonna answer no,
That's
because they're
true.
not taking it right now. So
That's
then it's
true.
not gonna go into their note, but in their yellow zone, they take it, so.
So
But
that's
I
what I'm saying,
use that
it's a
as a
PRN
daily med.
medicine,
I use
yeah,
that.
how do we get it to pull?
I only do daily medicines though, for that one.
I know,
But
but
No,
it's-
I mean,
it
if they're
needs to
on
show
it,
up as the
Flovent
med-
is
Well,
yellow
it
zone,
depends if
no.
you're talking about a physical or a sick visit. But if you're
I
coming
don't
for a
follow
sore
that
throat,
usually
I might
as
not put
medicine.
Flovent as your medicine, but if it's your checkup, you take Flovent PRN.
I guess, yeah.
Yeah,
I mean, you're saying you want them to show up in the med as well, med list as well?
Not necessarily, I'm just saying, I
I
think the way
usually
medicines
don't.
get
I
folded
usually
isn't
do.
right, right
Yeah.
now.
I usually don't pull,
And
I
don't know
usually
what
don't
people do.
even click on those to bring them in.
I usually delete it and hand type it in, which is stupid, but at least my
It
notes
makes sense to do it
at
in
least my
physical,
note's right. If
doesn't
you're
it?
reading my note, it's right.
Yeah, but,
that-
but
that
the
is-
information's in the chart, not the note. The note is sort of like a,
Yeah.
Yeah.
Right.
Time. So like if it's relevant, I always put it in.
yeah.
Like already taking Flovent out, you're
I
not
usually
approving.
do that in it. Yeah.
But
Does that
also-
have any implementation with billing? With
No.
how many medications are listed?
Because it is like Jen said, it's in the chart, this is just the
So-
actual way to do it here.
And when the patient transfers out of the practice, is it in the chart? Like, how does it print though?
I
It
get
doesn't print
tons
the
of
med
ER
section,
notes,
it
by
prints
the
the
way.
notes, right?
Well, no, but
Like
meds
the
are
consult
actually
notes.
the type of data that actually do transfer.
Just, right. So a lot of times when I'm writing notes, I'm thinking, when this patient leaves me because they don't like me, they go to the next doctor, what are they gonna think of my note? Right, so like, that sort of.
I had a Longwood transfer the other day, and I didn't totally realize they were Longwood transfer, and I was like, this problem list is amazing. Like, everything was so organized by problem, and I thought, I don't remember writing this when I reconciled this chart, but this is really good. And then I looked at encounters and saw that they were all from Longwood.
It is
And
nice
I
if
feel
it's
like
a transfer.
Yeah, but that's the place where you're looking for
Probably
information. I'm not ever gonna go.
For me, the bigger issue is if it pulls correctly into the physical
100
form.
electronic pages
Because
of notes, I've never.
honestly, there's only so much time I think we should be spending treating the chart, as my husband likes to say, rather than treating the patient who's in the office who actually needs our time. I don't wanna spend my time when the patient's in the office and I have someone else to see tinkering around with a physical form. So if we can pull it correctly into the physical form, so that I don't then have to go in and
Right.
manually
That makes sense to
enter the
me.
meds.
Absolutely.
Yes, the way the meds
Makes
pull
more
into the
sense.
physical form is not good right now.
Yeah.
But I think that is a place we can work on, and that we might be talking about tomorrow.
So maybe, is there a way that they can get pulled from Epic?
But some people will say
So
that the
say the
immunization
nurse
form
is
should just be the
they don't
immunization
take-
form, and they don't,
Not
like I think
like-
Jonathan said,
not at this time.
he just doesn't have any problems or meds to go on.
Broad and dangerous to have everything just pulled in, because stuff gets communicated
Yeah.
to people.
You know, I had it.
I would rather have not anything
I have
than
an
have
example.
everything.
Oh, yeah.
and having it
I
be
have,
just
well, this is a
that's
different
true.
example from the Bernelli kid. The other day, a mom was totally freaking out because her child on the health form was chromosomal, it was a genetic
Chromosomal
anomaly or abnormality. She freaked out. She said, that's not, I don't want that on his health form. That's, then I had to do a lot of research on genetic,
And you're
processing. Yeah, I'm like,
I think that's reasonable.
but
I
it's
don't
like,
think that needs to be on a health
Oh,
form.
because she doesn't want to communicate it to.
she doesn't want to
wherever,
communicate it,
school.
like she felt like that was HIPAA.
Oh, okay.
And if I understand what I studied, if it's in the process of, if genetic testing is in the process of finding a diagnosis and treatment, that's okay to have on a chart. But if it's, let's say, you're doing genetic testing to, find out if you've got, breast cancer in your family, things like that, that is supposed to be private. So it's a little dicey how that works.
Any sensitive diagnosis,
But
parent might not want to
it does
communicate.
bring to the point. Yeah, a lot of people don't
So
want
I
to
think there's a smell test with things, right? So if you're going to school and you're taking Ritalin, ADHD and Ritalin need to be on your school form. I think, right? But if you're going to camp, but if you're going to camp and you're not taking your medicine, I think it's reasonable to not have it on a camp form.
But is it required to be? I've had parents who don't want.
Yeah, and in that case, I'll take it off if they specifically
Yeah,
ask,
they
and I think
ask.
that's reasonable. But I think as a default, if you're taking a stimulant medicine for school, it's a reasonable thing to have on your form.
Yeah.
Right? But I might not put it on if you're going to camp and you're a Monday through Friday kid only.
So to be honest, I don't put any problems on a health form unless it's pertinent to their safety. You know, I just don't. If it's their asthma and they're going to sports camp, it's on their health form. But if it's, I don't put their problems on health.
So you really,
People
I'm sorry,
use
go
it
ahead.
and little kids where there's medicine and camp, like we're already filling out so many forms with our nurses and like hours and hours, and so I feel like anything that's actually relevant pretty much always gets duplicated on some additional form. Like there really aren't very many camps where they're like, here's your form and oh yes, the nurse will give you your medicine, but we don't need 67 signatures and a stamp.
yeah.
I think,
Yeah, because we had that with there was the Brunelli kid, where he had, it wasn't on.
That was me.
Yeah, that was you, that's right. And you had to fix it. No, but it was,
he has a peanut allergy, and it would be, that's why we're putting food allergies in the med list. But like Karen Howard was saying,
Wait, in the med list or in the allergy list?
I'm sorry.
Oh, we are, I didn't know that, because last meeting we talked about not doing that.
No,
Your first,
last meeting
last month, we
decided, because
okay, it will say
we
food.
want that on there. But, if your kid has a food allergy, you're gonna let people get allergies. No, it did not, it says no allergies, no known allergies.
So that was
What happened was the parents called and said it was wrong, and then the front desk was saying and just like,
Gotcha.
X out or.
But we learned.
I mean, they were trained to do it.
Yeah, it's not, it's the form, and we're going to, work at the front desk, and we'll pay attention to it,
Can we like
watch it.
touch base on this in like 2 weeks?
Yeah,
Can
definitely.
we still send them if we would, like, if it's part of our OCD, we like to finish it off by sending it?
Nothing's coming out at the wrong place.
Just end it.
But I like to close my note. If it's
You
printed,
can
I
still close your
it.
note.
Can't you
You
close
can't
it?
close
You
the
can,
note.
you can close your note.
I don't think you
Close
can.
your note
You
if it's
cannot
pending.
close it.
It's
cannot.
closed if it's pending.
No,
You
you
close
cannot.
it.
Oh, you can.
You
I
cannot.
close my note in the room.
Try for 2 weeks.
Yeah.
Let's try for 2 weeks. And if it works, no,
Or
so
can we send it if there are no shots or anything?
can we just try to keep it simple
Okay,
for 2
yeah,
weeks?
okay, try to
And then
keep
if
it
it
simple.
works, and then if it works, then we can back.
I don't.
Then if you
yeah.
can't close your note, then you can send it to a dummy printer.
Listen, you
And I
don't
get a test in between patients, like,
That's
it's
annoying for
so,
us, I'm sorry.
having my note done, and then I interact with Jen for 5 seconds, and I'm like,
1
oh, I
week.
just have blah, blah, blah.
1 week. Can we
one
try
day,
it for 1
how
week?
about one day, today?
One day.
1 hour.
No,
1 hour.
Catherine,
Yeah.
I would like to propose that I think if this works, then it answers one of the questions, right? And what it basically means is the nurses aren't doing it. Right now, we think the
I
nurses
think
are
we can
doing
figure
it.
out which ones aren't though, by looking at it.
Right, but if we can just do this and it works, let's take them out of it. Let's let the front desk do it. They're checking the patients out anyway. They're already in the chart. The flow probably works better this way. The second thing is, at that point, I think it's reasonable to say if the patient has no shots or procedures, that we can print the form.
Yes.
Right? I agree. I print the form before I even do a back exam half the time.
Yeah. And it's like when they just start going on and on and on, I'm like,
My
you know what I
forms
can
are
do with
usually
this?
done before the exam, which is, whatever.
Yeah,
But
get the form done.
Now,
So-
They're just like blah, 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 blah,
in
blah.
terms of the, do whatever you tell them to do. So when
Don't leave without your form.
they won't, please make sure you
When
check
there's a
out.
single secretary, I love all of them, but if there is one person at the front and she's busy and she's sitting at the computer and she's like, do you need a follow-up? And they say no, she'll be like, okay, because she's like got 5 people here and she won't realize it's a checkup.
Well, then, that's a separate issue we have.
Yeah.
I said, but I think the whole point is that the more routine we make something, like this way we know who, right now it's like, am I printing it, is the nurse printing it, is the front desk? We don't know. So if it's the same process every time, then chances are it's not.
You are, I've got it right here. Catherine. I am going to confirm for you.
I'm not occasional.
You are not occasional.
Because
You
my
are.
newborns, I don't print it for my newborns, that's the reason.
Which is
So
fine.
I think it's fair to
Which
say
is fine.
3 and up,
Yeah.
right?
And I see all the newborns.
Please, you know.
I think that's important.
Well, or daycare, you have to do it in
Right,
daycare.
but all kids 3 and up, maybe the
2-9
younger
is
ones,
daycare, though.
you shouldn't be counting our under 3s because they're not all in school. We should be counting the ones 3 and up.
Yeah.
That's not saying the younger ones don't need it, some do.
All right, we're gonna try this, and if you start to feel you want to pull your hair out, you need to call me.
She does that anyway.
All right,
She sits there.
I know. All right.
I know, I'll
If
count
it's
to
making
this
you,
part.
if it's making you wicked, stressed, you need to say
Catherine,
something.
Catherine, you know what you can do? You can change the circle to white.
Oh,
And
that would
way
be
for
good.
your OCD, it'll look like you're all done.
Yes.
You just need to sign it.
That's what I do when I.
Because I have to remember
I don't
to
want
co-sign note, then
Yes,
I remember.
yes.
I
We have a
know that I
system.
remember to.
Wait, so white means like I have my own personal work to do?
No, well, you can, we don't use
Yeah,
white.
make a color.
We don't use white, so you
Yeah,
can make it whatever you
Yeah, I
want.
do that if I
Use
know
it
all
for
the
your own
teachers
little
go on
flag.
the side.
That's how I know if I
Alright, but I'm
prep a
not
chart.
for something
I make them all white, and when I unwhite them, they're all
See?
prepped.
All right, are we good? So we'll say For Catherine, it's a day, for the rest of us, it's a week. Those are
We're
palate.
doing it for 2 weeks?
Yeah, well, let's just do a week, I think Catherine can stand 2 weeks. I don't want
If
to.
you send it, they can still have the same workload.
They are
Yeah, right, if it's there, then hand it out, if it's not, they'll follow this process.
How quickly can we get the front desk doing it?
I'll send something out soon.
Yeah.
And it's
It's almost
sending
a fun
something
little
out
project.
to the next area.
Well, I have to follow up.
Okay.
I have to follow up. No, they know how to do this.
I did
But
want to
I can
suggest
do,
as
I can
well,
do the quick
Amanda,
process.
once you learn this med reconciliation issue, I would go nurse to nurse personally.
Yeah.
And walk them through it, don't just send them.
Yeah, I'm gonna do that anyway because I gotta find out who's not scanning this before they're giving
Right,
them.
right, I think that's a
And make sure you
one-on-one.
include evening, or like sometimes
Yeah.
with the evening, I find that things don't quite work the same way.
How has it been, I've been
Great.
trying to keep 2 nurses on?
Yes.
It's been better.
Definitely,
Yeah.
yeah.
Kim's
Nurses
great.
in the evening.
Yeah, Kim and
Yeah,
Lisa,
yeah.
good, works much better.
Okay.
Oh, Lisa's back?
Yeah,
Good.
oh, Jen lucked out. Oh, no, she's not.
Lisa had her,
Good, is she good? Is she good?
she had a spa day last week.
Oh.
It was gifted to her? Yeah, I got very intense treatment, so it was really nice. Like, it was like all out, it was like a whole afternoon, evening. Yeah, she was excited. So,
Yeah, so moving on, so we decided, and Amanda's gonna go nurse by nurse to go over the reconciliation events. Good. Yeah, we want, well, first, quickly, we just wanna talk about the billing for the weight checks for newborn soup.
Yes. If you bill it with the physical, they're only allowed so many,
I think it's
OBs
six, is it 6?
within the first 11
Yeah.
months, 12 months, up to 12.
Right,
So what's happening is the weight checks, people are putting in a physical CPT code, but then they're putting in a feeding problem diagnosis or vice versa. So I think if it's not within the Bright Futures guidelines, the schedule, then we should bill it as a sick visit with the diagnosis.
It isn't. Many practices do a 2-week physical. Most do them as a physical. We've brought this up over the years.
but I thought.
Yeah, what typically happens is you don't always get that
that's what
denial because it catches up. So if they only allow so many within a certain time period, then the last one they'll kick out.
Yeah.
And it's not all insurance, it's
Yeah.
And then if they change insurance, so there's a lot of variables, it doesn't.
so we can do it, you have physical and bill it as needed.
So we can try it that way, but I think that it's too risky because then.
So
We
the
don't
issue
do
was
that.
that when we type in a newborn weight check, it's generating a physical, ICD code, is that right? Because I always do a 99213 for a weight check.
Yeah,
So, but if you-
But then you put a
can't go with
routine.
one of
You
those.
can't put a preventive care code.
You
You
can
can
go
go
with
put
diagnosis.
in
So I guess that's
check.
our problem, is we
Yeah.
didn't realize when we put in newborn weight check that it was associated.
You gotta put in a
But
feeding
we
problem,
did
a
after
weight.
we-
Yeah.
We can't
weight
bill
gain,
weight check
breastfeeding,
in newborn
yeah.
to 28
Yeah,
days.
that's-
Right,
That's what I
I
had
thought
to
that
do.
those codes are so nice.
Yeah, me too.
Every
Yeah.
day.
On 8 days,
Yeah.
8 to 28 days.
So pretty much anything with a Z is not,
So we should
doesn't
just
go with the
we
sick.
should just go back to feeding problem.
Yeah, if they have a feeding.
Is that legitimate, even if they don't have a?
Well,
It's a weight check.
you can find something that.
I'm there to make sure they don't have feeding
Regurgitation.
problems.
It's like a roulette wheel.
So the reality is.
So I feel like that
if
must
it's-
be
If you see someone on the third day of life, right out of the hospital, their weight's down, they go, well,
But
well,
that's
that's
a
a
well
well,
check.
that's a
You're
well
still
check.
there to
But their weight's
evaluate
down,
their
they have them come
feeding.
back in 4 days, yeah, come back in
You
4
can do
days,
slow
they
weighting
gain
too,
8
but-
ounces, everything's beautiful.
But the reason you're having them come back is a weight problem. So you
Right,
wouldn't
but
have
But
to
it
do
doesn't
that.
really matter as long as
Okay.
it's
Yeah,
problem,
that's
that's the point. Like,
Right,
you
but
just
our
can't
bill
use
is
a
feeding
preventive
problem.
care.
Which I
Slow weight,
But
you
you don't
don't
have to
ever
write
think
that.
you
But
want
it's
this
not
by the
slow
way.
It's slow.
But,
No, it is, but to that
it
point
just can't
it
be
was.
like the
Right.
breastfed.
Okay, so slow
Yeah.
weight.
Yeah, yeah.
Slow weight gain?
Or
Slow
feeding
weight gain,
problem,
or feeding
or
problem.
stellar weight gain.
And then you wouldn't have them come back again if they're on course,
Hyperbiliary.
correct?
Well, we
We
do,
do normally do
sometimes
it.
they're gaining and we still have them come back at 2 weeks because we like them to pass the birth weight.
That's true.
Yeah.
So
Right,
that
so
is
that's
kind
still
of
a
a
slow
well
weight
visit.
gain until they.
Well.
Not if they're anticipated to. do
It's
fine.
slow as babies are slow.
That's why I don't like feeding
Just come up
problems,
with
because
something.
it's a problem.
So
Right.
just
I
don't.
like when you're
Well,
looking, because
it's
when you're
all a
looking at
game, it doesn't
encounters
matter.
Yeah.
and it's named and you see that it was.
Weight's down.
not at Berkeley yet.
I feel
It
like
sounds
our
a feeding problem, maybe.
yeah, then I guess.
It sounds to me, I don't know,
The problem is, so
The
what we're talking
problem is
about,
we
we're talking
wanna
about
do
a
a
normal
checkup, but we
baby.
don't have enough checkup times,
We're talking about a normal baby.
allowed checkup visits.
I would say if you can find something,
Yeah.
put that in. If not, and it's a routine well visit, we can try it, but there is that risk that come 11th
last
visit,
visit,
or
yeah.
it might not even happen until
The
the,
12-month.
The two,
30 month.
200, that's 200
But
might not be.
it's still, it catches up. The only one I know for sure that you can do is Mass Health, but now that with the ACO, I don't know if they've put, Tufts has put a restriction on that. Because they're managing.
so try to
But the
use
fact of
it.
the matter is, some of them, timing-wise, are off anyway,
Yeah.
track. So sometimes we don't get enough, like, we're supposed to have a certain number of visits
know what, we
between
can
0
do?
and 15 months, and sometimes we don't hit that measure. So then, we had talked about adding it as a checkup, since we do, anyway.
Adam, we can do feeding problem previously, now resolved. There's one like that.
Is it a Z code?
It doesn't,
I think it's a sick visit code. What's that on the difference?
It shouldn't have a letter in front of it.
Okay.
No, it's like an L.
Z is, preventive pretty much.
Z's,
Yeah, but it's sick visit code, isn't it just a number?
No, it's not like L.
No, the CPT codes are
Oh, they're all
9921.
But like
No, I
feeding
know, the
problem.
diagnosis code.
Yeah, no, that will
I
have.
thought the sick codes don't even, don't have letters.
So really avoid a Z code for weight checks
All right.
unless there's.
That
and we get it, we
Right.
get it, the name of the other stuff.
No Z, no B, right?
I can't have my thing.
Do something else.
I'm just trying to get my notes.
We're all just a different kind of OCD.
Yeah.
All of us have issues,
Okay.
and they're all different
All
issues.
different.
So, good luck to you.
Yeah. Good luck to Sue. All right, so we've had this on the parking lot for a little bit, and I thought it would be a good time to bring it back up, is using chaperone. A few of our colleagues, and, you know, a couple of them, they all use Scribe, so that's a built-in chaperone. And I haven't had a chance to read it yet, but the PPOC has a policy on chaperones, but I think, honestly, I think it's taken from the AAP, so you've probably already seen it or read it, but, I don't know, I'll let you, talk about it a little bit, Adam, and then see how you guys wanna weigh in and how you feel about it. I'm a little sketchy on how we would operationalize that if we were to use chaperones when you needed them. And I think the question was, do we make it a policy or?
So during the women's gymnastics Larry Nasser trial, I was just sort of thinking a lot, and you know, I started. Usually, it's the parents sitting in the chair and the kids up on the table. You sort of stand right there and you do everything. I started like moving my body so that they could see what I was doing, and I just started thinking and saying, well, all any of us really are is one kid away from saying something, and it's really hard to practice pediatrics again, you know, especially around here, and just wondering if we needed to be a little more explicit in either having chaperones to protect us and our patients, but I think mainly us, although maybe that's a self-serving way of thinking about it.
No, that's really.
But
liability.
most likely to protect us, but also, I wonder if that would be something that would be appreciated by parents anyhow. So both from sort of like a good practice perspective and from a protective perspective. And when I was thinking about it, what I kept coming back to is the only reason not to do this is because it's a pain in the neck and I don't know how to make it work. Right, so the only reason I wouldn't want to have someone in to do certainly a genital exam or breast exam or something like that is because I don't know how to do it, without hiring more people, and it's the logistics. So once I felt that, I felt like, duh, we should totally be doing it, we just need to figure it out. And I don't know what other people think, but I wonder if at the very least we need to be asking, almost getting informed consent in a more formalized way and documenting that. That would you like to have a nurse in while I examine you? No. Patient was asked if they would like to have a nurse in the room and chose not to. But I don't know, so I don't have an answer. I just have a question.
So I think that the first question, because I've been asking this for a while, is the utility of the male GU exam, and certainly a breast exam in an adolescent female is highly debatable anyway. Like if you look at all those USPTF whatever recommendations, they'll say no. Like screening is going to pick up some benign blah 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 that's going to send this kid for an ultrasound that's going to turn
For
out to be nothing.
post-pubertal.
Yeah,
Right.
Yeah.
Agreed.
So I think that's the first issue is we probably should standardize what we're all doing first and then decide how much of it needs to be super, you know.
So I have to be honest, I don't do many general exams post-pubertal, particularly for girls.
Agreed.
Yeah.
I just don't. I usually give my little spiel and I say, do you have any questions or concerns about anything in your private area? XYZ is normal, XYZ is not normal. I don't have to invade your privacy if you prefer I not. And that's usually what I say, and I'm done with it. And I don't usually, the little ones, like the 9-10-year-olds, so.
Not a
well,
problem, not a
there's
problem,
no
parents
touching,
and
blah, blah,
learning.
blah, like, whatever.
Yeah, and I
Right.
do talk to them about.
It's 13 to 15-year-olds.
Yeah, but I think we should talk about what we think is actually indicated and standardized, so that it's not like, oh, why did last year she didn't look and this year, so then it's going to look even.
So you use our.
So I think it's very muddy.
Also,
No, it really is. That's why I think we need to decide.
I feel like girls it's a little bit different because to do sort of a really good exam, it's much more involved and we've got tables that push up against the wall, and I sort of agree. On the other hand, my feeling is like we don't necessarily want to be the healthcare providers for above the waist and below the knees.
Right.
And if you never look, then when kids come, maybe they have a problem, they feel like, well, I don't feel comfortable bringing up this lump because like they don't want to look at stuff or they don't want to talk about it. So I only worry about if we sort of say standardly it's not part of our regular physical exam.
Do you routinely do GU exams for all your adolescents?
For boys.
I do boys. There's not much to do for a
Like
girl.
a visual exam.
I do more.
Catherine's very hands-on.
Stand up, it's easier for me to. And then I ask, is it okay if I examine your testicles? It's part of what we do to make sure there's no lumps or bumps or things that are abnormal.
So I think can agree for that testicular exams aren't necessary.
Yeah.
I think I haven't been. I think Lester said a couple of years back we haven't been doing.
Yeah.
We don't need to touch it, we just need to look at it.
Just to take a look.
And that should be enough to see the vast majority of hernias and other things. Yes, it's not going to pick up on small humps and small lumps.
Yeah.
That's where we should be educating kids to do testicular exams.
It's true, all the varicocele I've picked up are just varicocele and they don't do anything.
No, but
one was surgically. Correct.
No, I think obviously patients come in because there's something wrong with
Right.
it. Like then you have to look, obviously.
But they have to be willing to come to a parent and say there's something wrong with my scrotum, and that's my concern about.
Right. So
I do always say, if you ever feel anything,
yeah,
you need to tell somebody. Yeah. Don't just diagnose it on your own.
I think
if something feels different.
I think some
so I do say that, even if I don't examine.
So I think we can agree that when the growth curves is solid, and there's no more growth, that you don't have to do the exam if there aren't concerns. Yes, is that reasonable?
Well, what about us there?
I don't even think you need to do a visual GU exam on any penis problems.
Yeah.
I usually will ask.
Although sometimes if they're having lots of extracurricular activities,
yes,
I might say, when you're, having, when we're screening you for chlamydia, sometimes I'll start looking also, just as a cursory, before it's okay.
At least it's back.
But so
I usually say, let's see if you picked anything up here.
So can you guys at what point do you stop doing testicular exams for everybody who's not doing them at all? Ever?
Yeah.
Outside the newborn period, but to make sure they're both there.
Once I know that you have two testicles.
And then I look for Sanders meetings.
I have picked up like an 8-year-old who undescended. So there are kids who have retractable testicles that can ascend.
Right, like
so
you have to visualize both testicles.
Yeah.
Okay.
If you can't visualize them, then you
but
have to.
Assuming if it's obvious for me, I'm just. Okay.
I think you're basically Tanner staging.
Okay.
So what's the?
Which is kind of what I do with breasts. As best I can, because a lot of times they keep their bras on and it's so hard.
Always keep their bras
on.
on.
Yeah. I I think you're 2 or 3 or 4 maybe, it's hard. But I
But
think
like
yes.
post-period, I feel like we don't.
Yeah, I don't. It's gonna end up getting sent on to ultrasound and surgery, all for nothing. Yeah.
So post-period,
So-
basically don't do breast exams.
No,
I
yeah,
don't
gross, they don't do them, no.
Isn't the recommendation not to do
Yeah.
breast exams, and even not even to bother teaching them to do breast exams?
Yeah.
Really?
I think a provider's breast exam is still recommended. I think it's home cell breast exams.
I think they say,
Provider's breast exam at what age?
provider breast
I mean,
exams
the
don't.
lower the incidence
I'm
of an
pretty
issue.
sure.
I think,
The screening.
So my physician went over the guidelines at my last checkup and was like, the new guidelines, just before I did not do a breast exam. And I was like, oh, okay, why don't do me there, so let's hope.
Well, and it's totally different when you're talking about an adult versus a
Yes.
17-year-old.
Like, in our population, you pick up very little
Yeah.
pathology with the breast exam.
And most of what you're gonna pick up
I
is gonna
do
be
Tanner
benign or false
staging,
positive.
and I ask them if there's any concerns, if they've ever felt a lump or bump that they're worried about, and that's about it.
And actually, usually at the time I'm doing the physical exam, when the parent is out of the room, is when I'm asking the sensitive questions. About substance use and sexual activity, and I think having a nurse in the room might make that them less likely to talk about their daily life.
Well, Adam's saying they would just come in for the exam and leave, right?
But I'm
Or
just
they
saying
might
that,
just
like,
come
I'm
in
using
for-
that time.
Yeah,
Yeah,
I talk while I examine.
Or they might just come in for the GU exam also.
I think the timing of that.
That's what I
was
thought.
So I
what
guess
I
if we're not doing a GU exam, is what we're saying.
Right, but you still have the younger kids.
Not that many, like by
Well, with
13.
boys you do,
The parents are in
The
the room.
parents are in the room.
not for 13 and
Oh,
14
they're
and
like
15
Like
year olds.
even just like the visual, you're saying, even if we're not touching, but we're Tanner staging.
Yeah. You know, in the same way that like, well, I don't know, in the same way that I wouldn't drive a teenage babysitter home alone at this point in my life either,
Yeah.
you know,
Do you think it's a male thing,
maybe.
maybe?
Well, I do think what you said is true.
I think we're more vulnerable.
Well,
There's a
you're
more
definitely more
sensitive
vulnerable.
nature, especially after that trial. I mean, I think a lot of parents are looking at that.
You don't
Those
hear
parents
about
were
it.
not in the
Respect as a
room,
male
though,
physician,
either.
that's
I mean,
hard.
Some are.
That's where
Well,
they
that's
were.
true. Well, I guess, yeah.
Somewhere they were behind a curtain, they said.
So,
Some parents were really rude.
Yeah.
so I think, Mike, what do you think? You're in the academic
Totally sorry.
culture,
Changing diapers.
or closer to it.
You awake back there,
Yeah,
nice?
you're a man.
I think I'm asking
Their kids, their desire for their
For what, sorry, what do you
Maybe
guys?
if you have to do a
for
genital,
the chaperoning.
but like, does it help a guy? I mean, I guess it just helps your liability if it's like 2 women in the room.
Yeah, ask them.
Yeah, we could ask.
You know, I always, I don't always say, but a lot of times if I can see the kid is on the anxious side, most of the time with just you and have mom and dad out of the room, comfortable to have mom and dad come in for the exam. But I mean, it's just giving them options as long as you.
And don't you think you should document that you gave them options? Maybe that's the
I
answer.
think that's probably.
I mean, that's probably
When
the
people
answer.
defer an
I
exam,
know, but you still, I don't know.
I mean, you're still
I'm
vulnerable.
catastrophizing a little bit here,
What if-
right? But
Yeah.
again, all it really takes is one kid, and you can't work anymore.
What if the parent is in the room for the exam and out of the room for the interview?
Right.
You may not want them.
Some parents don't.
Yeah.
Like some boys don't want their mom there while we're looking at their business.
That would be
They're
fine.
not gonna want to nurse.
No. Right.
You know, and so maybe the simplest answer is clear, is really informed consent, and documentation of informed consent. That you specifically ask with the parent present.
The parent doesn't walk in, and I'm like, yes. I almost always walk into an adolescent room, and the parent's like,
Yeah, is that
and they're almost always there when
Most
it
of
starts.
the time, right?
But that's a bigger, I mean, the flow of the adolescent is
Yeah,
a
it's
bigger issue and a bigger
Right.
question.
But can't you ask the patient with the parent in the room, even if you're not just about, I mean, couldn't you just bring that up while the parent's in the room?
If they're in the room.
Um,
If they weren't in the room, then I'm not
Maybe we do
going
need first, to come up with a consensus about what we're gonna do.
I agree.
Yeah.
Like what exams
I think
we
that's
do at
the
which
best.
Right
age
now,
is.
I've written that
important.
testicular exam's not necessary, visual is okay, counseling necessary when,
It's sort of like age dependent,
like,
so I
no
think.
more, I wrote no more than post.
When the kids
Right,
start
right.
growing,
Post-pubertal,
one measurement.
visual okay. And
Well, do we
then-
wanna say visual is okay or visual is standard?
Oh,
Cause I think
visual
visual
is
standard.
Yeah, I think
standard.
I just think otherwise, I think that's more of a,
Okay.
That opens us up to more liability, like why
I think that more
why
so
did
than
so-and-so,
shepherd.
you know,
Yeah.
actually
Oh, yeah.
manipulate
Someone's
versus
not
somebody
looking,
else
or
that went
just
off.
someone's looking and
Right.
like touching and someone else is
And
doing
then,
a full.
and then somebody else doesn't look at all.
Okay, I'm not doing any more, okay?
Well, why don't we,
I'm all done, I don't even like
why don't
them.
we decide that?
Okay,
So let's like draft something and
Pretty good.
circulate it and see what
Okay.
people think.
okay.
Because we all have probably opinions about.
Not being thorough.
I know.
Over
I'm just gonna be like, I'm in, the lot
How are we
easier.
how are we feeling about listening to hearts? We still doing that?
Yes. I generally make sure they're present.
All right, assigning PCPs in preparation, so, you know, there's a difference between assigning a PCP internally in our EPIC system and billing under a PCP, okay? So, nurse practitioners in our practice, we don't, you know, generally we don't bill under them because you don't have panels and, you know, there's a whole host of reasons insurance-wise to assign our patients to their preferred PCP or the person they see most usual. And, you know, part of it is, you know, for consults, you know, follow-ups.
All these external
all
messages that get routed to us now,
Exactly.
like I end up with like 6
Exactly.
messages from
Have patients make certain appointments, but I think they have to be assigned, right?
Right,
You'd
so-
be better at that. I thought you wrote September enhancement.
Are they gonna do it online?
Right, fine.
All right, so,
Yes.
so we have the capacity now to allow patients to do self-scheduling. We have to open the visits. What they would see from my chart, though, is you're only allowed to select your PCP or a provider you've seen in the last 364 days. So if they haven't seen you for their checkup and they're assigned to someone else, you wouldn't be the person they could choose. There is, yeah, so we haven't opened that in our practice for, not only because of this PCP issue, but because like we're a little bit concerned about which ones, who's booking what, and like we're, as you know, like always very fussy, and everybody gets fussy about how much time was given, and so the appointment slots is kind of an issue. There is an upgrade coming, which will happen. There is actually, Epic is switching to quarterly upgrades, and the version we have is the 2015 version of Epic. There is now a 2018 version that's been released, but there are also upgrades to 2015. We're basically going to do all the upgrades at once in January of next year, which it won't feel like 4 upgrades. It's just going to be like basically getting us the most current thing. One of the features of the upgrade is that patients can be, this feature where they can pick who they want to see for the appointment could be from a pool. So we could create teams if we wanted to also. And they would be assigned, the patients would be assigned a pool, and then they could pick from the pool. But still, basically everything keeps coming back around to the fact that that our PCP assignments are such a mess is really affecting us in many ways as we use this system. And the idea that the upgrade is coming in January, I feel like now, and start fixing it so that the people that you know are your people can be under you. And there are some people that don't want to choose, and I think that's which is fine too. But like certainly for a lot of them, and it's not necessarily just the skip patients, because people are complicated in other ways, are not assigned to skip, and it's very beneficial for them to, in a lot of ways, for us to stay consistent with our. Now we're doing behavioral health, and it's happening all the time that follow-ups are.
patient that you've never met before.
Yeah.
Oh, yeah. Lester's 25-year-old, who's like a alien and almost in her country for their SSRI and their Adderall or something.
Yeah, no, that must be really hard.
It is really hard.
Yeah, no, I think honestly, I mean, it's not just an inconvenience to us. I think it's a disservice to the patient.
It's a disservice to the patient.
Absolutely.
You're
You want to start where someone already knew where you were.
And you're at a disadvantage. So,
like,
yeah, it's difficult.
I mean, it's not even that, like, just plain old reflux meds for patient that Meredith did a consult, Jonathan follows her physicals, is somehow in my schedule when both of them are there on that day.
Yeah.
Like, none of that makes any sense.
It doesn't,
That's
it
a
does
nursing
not.
book thing, that's not.
Well,
Well, the problem
They
is
might not
somebody
have
puts
any
her in the
availability.
stew.
Right.
They had tons that day, it was
Yeah.
not, that was
There
just,
has been.
That happens a
whoever
lot, I
booked
think
the
that could
appointment,
just
put
be
them
an
in with
update
whoever.
too. Like, just, I think that it's hard, you get so, like, there's so many
There's just
calls
so
and
many
you're like,
people
okay,
booking
well,
appointments.
they just won't think outside,
And then
yeah.
looking for an opening and then you hit my
Right, but I think
schedule.
that's what needs to.
But this is
be
part of
tweaked.
this
That's what
thinking,
needs
like
to
if
be,
we
yeah.
kind of try to, we are big enough now,
Right.
it's not just four of us, like,
Right.
we have to be thinking from everywhere, the people giving the appointments on up.
Yeah.
That like, we need, the schedules you're looking at need to be certain, trying to be certain, unless it's like a, you know.
If it's a new problem, nobody's ever seen before, whatever, like a new
Yeah.
rash.
Sometimes they don't always know, and that's.
And then they bring
huge.
up their reflux while they're, that's, again, that's unforeseeable,
And
I
patients
totally
don't
get
always
that.
tell.
Right, I mean, if you're
Yeah.
relying on
People are weird.
You're
about
But
relying
like
on
when the chief complaint is reflux, and there's a visit for reflux with a different provider, plus their regular PCP is there that day, like it just doesn't make any sense to have a third cook.
And
It
it
makes
makes
sense to ask, have you been seen for this issue
Yes.
before? That's a pretty simple question.
Haven't we brought that up before though?
Yes, we
I
have.
brought it up a lot of times with the nurses.
It
you
should
know.
be a.
But I never brought it up at the front desk.
Yeah.
Is it happening more since the front
It
desk
is.
is
Yes.
booking the appointments?
Yes.
Yes.
So that really is one of my
Concerns.
clinical questions.
Yeah,
don't
like
think
last
it's a
week
good
on
idea.
Monday, Jen Harris saw this teenager for a really she had like mental status changes and she felt like detached from, I mean, it was a
Very
crazy
long,
visit.
crazy visit.
She ended up having to send her to the emergency room emergently. 2 days later, she needed to follow up from the emergency room. Jen and I are both in the office, we both had openings, and the kid comes to see me. So now it's not for me that I'm sifting through emergency room notes and Jen's note, whatever, I think that's terrible.
It happens all the time. Happens all the time.
Right, I mean, this is to me a little bit more of an extreme.
But I do think that like this is something that this is a bed we made.
Yeah.
Because other
Yeah.
practices are
Right.
so strict
Oh my
about
God.
who their patients see.
When I was on paper charts still in Swan, it was like a purple chart was my patient,
Well, we are in the process of
so
getting
and
new
so's
families
patient.
because of that rigid rules. Their doctor left, they were assigned a primary who cannot see them till January, these are
Yeah.
kids, it's April. And their checkups were supposed to be in like May.
No,
And they're like,
agree.
this is
Yeah,
us,
I'm
we
not
need
saying
to
we need to be
Right.
average, and
We
like
gotta
Long,
find a
and Longwood
balance.
has a thing, I had a family come because they're not allowed to split kids, like everybody has to see.
And it is funny, I noticed that the parents will have one kid see me, one
That's not
kid see
even right.
Jen, one
I
kid,
think we
you know.
really have to find a balance. And I'll tell you honestly, we've been batting this around for
Yeah.
a good year. And yet the other day, Adam and I were just talking about, how would it work.
So
with-
how does this sound?
Yeah.
You have, we're divided into, with its own scheduler and a dedicated 2 or 3 nurses who know you. So all of your scheduling goes through the same scheduler, sort of like the ENTs of children. Doesn't that sound lovely?
Too, like at Brigham, when I check out.
So we have challenges with space.
The bottom up again.
Exactly.
Yeah, no.
Which we probably need to do.
Right.
That's how Allie's new practice is.
Yeah.
Each provider has their own nurse, they have the
yes.
exact same schedule.
But you know what, they
And
don't
Al-
have patients back.
Well, that's wrong. That's just wrong.
Because then their own scheduler, there's like an hour in the afternoon where the doctor's in charge of calling patients back.
That's my concern, even like ortho care, especially in Easton, I mean, they do a very good job, it's huge volume, so they have to be able to manage like this crowd, but like when I called this week for my trigger finger, whatever, and I had to leave a message just to get a call back to get the appointment scheduled, because that doctor's nurse, her schedule is long, so you're gonna fall into, and when you're busy, I don't want someone else to call me back, then I have to remember,
No,
did they call me? I want to just get the appointment made, like.
We might want to do something where, we have certain people at the front, or we have a call center that takes these calls, but that eventually it gets to the right scheduler or the right nurse or.
Well, maybe we just
the right
starting to
pool.
assign the primaries.
Yeah,
We haven't done that.
I think that's the first thing.
Just do that.
Because I like to default to the name at the top.
Exactly, they can learn to default to the name at the top. Now, I think that the front desk, the nurses can certainly be asking, who do you consider to be the person that's your primary? Not your insurance primary, but your primary here at the practice. But I also think there is a way, and maybe, Steve can show, you guys can ask, can change it
Yeah.
yourselves.
Tara's been doing it. She realized she could put me in.
Yeah.
And I think Helen Lang was still listed.
Right, oh, different Tara. But
No, Tara O'Keefe.
Oh, okay, so you guys can do it as well, so,
Yeah.
you know, maybe, I don't know, do we have that here, or?
Yeah, it's under
Epic, can we get Epic up?
He's
No.
I'm sure we can get Epic up, the question is who we wanna go in as.
I can go in, I'll do it.
Jen.
Because I don't know that I'll be able to get what you wanna see without being a provider.
We can look at the charts for people that are coming this morning.
Yeah,
and
just
I'm
log
sure,
in.
like,
Okay.
Jen can log in.
Are you saying we can change it in the
You can-
chart?
you can
In the
change it.
chart.
That might not be, that may not fit with what's in their
it doesn't matter.
insurance.
No, don't worry about insurance.
So it's just
We've already,
our-
yes,
Yeah.
we've already shagged that one down, because I was a little worried about that as well.
the schedules, they're having a really hard time fitting the patients that typically come to me, so my primaries,
Yeah,
because I just don't have a lot of physical spots, and they're like, you're booking into September now.
Yeah.
And whereas a lot of the other providers will have 8 physicals allotted a day, I think on Tuesdays I have 4.
Yeah.
So I think
No,
we
no,
might
no,
need
no,
somehow.
no,
Have your
no.
signs ready when I realize to see how many you need for a year.
Yeah, typically
Yeah.
what I have done, no, but I have
It's
given
gonna take us a while to.
NPs more
Sick, yeah.
yeah, so that's an issue, then I gotta
I
look
I
at
think,
that.
I'll talk to the front desk, they, and I was like, I don't know what to do,
And
but maybe it's
typically,
just that.
in the
we need to-
winter, typically, providers are getting, 8 physicals.
But you're right, I get a lot of requests for
You've
Yeah.
got a bigger following,
Yeah.
but we can't do that now because they're not sick.
Alright, so here's
Because-
one.
Then what happens is we
this
see a lot of
kid
the newborns.
has been my patient for over 10 years, but still says the
So this is
PCP
where you
tally.
want to, where you want to navigate to.
So demographic, and then do I just click on the PCP? No, I can't click there.
Oh, you want to.
Where do I,
I
how
thought
do
you knew how to do it.
I? No, I
So,
don't. I knew they were gonna be.
So, we'll close this.
They might not have been in.
So this is the patient here.
Yeah.
But not everyone.
Did you just open it? You can't open it, Steve.
I thought you had it open.
No, I just was looking at the view,
Oh.
the chart.
Well, now maybe you can do it, maybe we
What day is it for today?
Yeah.
Okay. well,
hopefully he'll come, he's gonna come, Mr. Egan.
We're all professionals. Plus, there's the erroneous entry
Yes,
Um,
the template?
problem list, apparently.
Yes, there is.
I'm getting messages about it.
Smart set.
So,
Erroneous
I
entries.
think-
Okay.
all right.
We did it the other day, Jen, it was easy.
I think it's every chart review.
I know that I can do it from here,
No,
but
we're
this
in
is.
chart review, but what I'm wondering is it may not be in Epicare.
I think it's.
I don't know that, I don't know that we have the privileges to do it. I think the front desk.
You did it.
We did,
Yeah.
remember, we were in me, but then we went,
Go under like
Under
that,
counter.
where Jen was before. Where were you before? Under,
And I was like, oh God, look at that little.
Demographics.
yeah, it's, or maybe,
we definitely went
outside?
into Jen, because,
So there,
Yeah.
click on demographics, and then,
do you want me to hold it? Now go to,
it's somewhere
go
here.
to
I think.
additional, go to additional, go to additional.
Yeah.
No,
that's clinical information.
Oh, here.
provider.
It's grayed out.
So,
So you may not be able to do it unless you're front desk.
oh my God.
I don't think,
Oh, wait, I'll.
maybe it wasn't there, maybe it was somewhere else.
But that's,
That's where they set it, right, Sue? The front desk?
Well, not, see, this is from the chart, so it's.
I know.
well, someone
Yeah.
called.
So wait, where was it? Additional?
Oh, maybe it's care team?
Oh, I think it was
There you
their
go.
team.
Yeah,
It was-
care team.
It was
Oh,
care
wait,
team.
where did you get the care team?
Oh,
Sorry.
there you go.
Under more,
Oh, more down there.
and then care team.
The more buttons down there.
No.
Oh, yeah, but yeah, so anyways.
That's
You
okay.
know there's more, but you can move it over to the
So now
navigator,
can you
which maybe we
change it?
should do, and then that's active.
All right, so this is actually the patient that comes to see you.
Yeah,
No, it's not.
Up the top, Jen, add.
oh, right, search for PCP. Yeah.
Okay.
Karen Halley will no longer be the
PCP.
CCP.
She's
And
general.
Now
then
she's
you
just
click
accept, and now it's
And you can, so once we
Oh,
decide
wow.
on pools, we can add, let's say, Jen Hyde
Search
and
team
member.
Catherine Austin.
Oh, cool, okay.
That's cool.
You know, Ronnie again.
Right?
It is nice when they're seeing a specialist
So
too,
it's via
and all
care
the
team,
contact info
you have to
is
change
always-
it, as a provider, you change it to care
Yeah.
team.
Alright, so then I'm gonna.
But it's true, because children's, then
too old for my
Tammy's
own
job
anymore.
is easier. Think of all of the PCP, the consults that come in for
Flow
Karen
is
Howard,
gonna
they
make
can
a
come to me.
huge difference,
Yeah.
because they're gonna say, what the hell is this, why am I getting?
So I just moved the care team out into my left panel under history. So now,
Oh, cool.
when I open the page, so let me go to somebody else.
Make sure you see the patient.
Lamb. Keep the small computer. That's already me.
Jen, you can also access this under chart review, right? You don't have to have it in your panel.
This is chart review.
Okay, so you don't have to have it in your panel.
No, I'm just picking from these.
Is this something front desk can be doing
Well,
also?
Yes,
absolutely.
and they have.
But can they also be asking, do you see any specialists to put in part of the care team?
That would be great for the skip kids.
Well, Danielle could start it,
Yeah.
little by little.
Do it, but I think that would create, during busy times, it would create a lot of backlog, if we're
Yeah.
updating a lot of that.
For the skip kids, I think Danielle could do
And
it.
there are times we can certainly do it, when we're not crazy.
Oh, because he was open.
Yeah, I mean, I know you guys are busy, but if you had time
Yeah.
to do it,
And if we knew how to and it was easy to do.
yeah, yeah. I mean, I think if
But I'll
everybody
also ask
pitches
the
in,
front desk to,
yeah, if everybody pitches in, you know, we'll get it done quicker.
So Carol, is what you're saying, we can go in and do this now if we know it's someone who really is our patient,
Yes.
but Karen Halley is listed as something, we
Absolutely.
can go in.
Yeah, absolutely, just pull them up, go to chart review,
Could
and
we send a e-message, or my chart message to all the 3,000 people we have, asking them to identify something?
Yes.
Do it on their own, and the patients change it?
I don't think so.
know, I don't think so, I don't
I've never
know.
seen
I
it
don't
in
know.
my.
How does that feel like? Take it up on
No, though, I mean, and maybe in demographics, they can, yeah, look into that, they might be able to, because they can, you know, they put in their demographics, maybe there is a
You
question.
know, and I think along this whole line of questioning or thought, I think one of the things is, but I think the next year is going to be maximized.
Yeah.
Like, we've sort of like gotten through it.
Yeah.
And I think the next year, we're really going to have to focus on sort of cleaning it up, you know, making sure our problem lists and histories are sort of in place, and then using things like this and I think there's a lot of potential to improve how we use it.
We should probably have a section, every provider meeting on optimizing Epic, and, you know.
They're all Karen Halley, by the way.
Yeah, right.
So one thing, Epic, that I know at least all the providers I work directly with have concerns about is the new option, the patient advice, where patients email from home aren't getting any nurse triage. So I had a patient ask about Claritin, it just got sent to me. So I sent it back, I had time, but like, that's a nurse triage, you know, like, can my kid take Claritin?
I want to understand, it's coming directly to you.
No, it goes to the nurse, they read
We
it.
have it going to a pool. We have it routed that those messages go to a pool.
And then it comes to me, but they don't answer it.
There's like literally, it just says forwarded by whoever.
Yeah.
And there's no nursing, no.
So that's, yeah, that might be nurse, because I do feel like there's probably some that we don't actually get. That's definitely a sign.
On the
But
other
I get a
hand,
lot.
I had patients send me a my chart message that
Takes
I actually don't know
forever.
where it was, but never came to me, and then 3 weeks later, it still isn't in my inbox. But I'm not sure where then it resides.
Yeah.
Never
It's
know.
still in
So
the
the
nurse
fee
triage.
question? I don't know.
Well, again, the advice thing, I think we just need to remind the nurse, like,
Yeah,
all the
if
messages.
they can triage it and answer it, they should.
And if they can triage it, answer part of it, right? And then say, you know what, I'll send it to Catherine to see if she has any other
Well,
suggestions.
can they handle it just like a phone call? If
Right.
it's something that's
Exactly.
right, then also it
Yeah.
gets somehow looked at by us.
Routine.
Well, it is a phone call, because basically it's the family at home saying like, well,
No, I know,
What
I guess
you
what I'm
want.
saying though is
You
can
know.
it be routed like a, like they give the advice, but then we
And then route it
to
to
you, so that we
Yeah, but when they
know
address
what
it to
advice
us, it seems weird to not answer it.
What?
But I think they,
But like
is
if
there
it's
a
a
nurse?
nursing question, like what
So there's
goes to
questions and
Claritin,
there's
like that's a
questions.
waste of time.
Right,
Like-
there's questions for the provider,
Right.
and then there's medical questions for the office.
Yeah. But I do agree that sometimes if it's addressed to me, whether it's a simple routine question or not, I find that they felt comfortable enough to reach out and ask me personally a question. And if I turf it to my team, then I'm being disrespectful.
But I guess
So I don't mind.
I think
From
you're
the
not
home
getting as many
perspective.
questions as some of the people.
What are they seeing
a
on
ton
their
of
end?
That's a
questions.
fair assessment.
What are they seeing on their end? Because if
Yes.
their options are only to choose a provider to
it's 'cause I
email
answered
questions,
first, so
then
people
it's not
do
because
that
they
and they
didn't want a nurse
forward it.
answer, it's because they have a provider.
Yes.
Let's try to have one conversation.
Okay, so the drop down menu,
On the drop down.
they can't direct it to the
But you
nurse.
can tell.
Or sometimes you'll say like, I couldn't find whoever.
Right. I think that's that they think it's coming directly to an email to me.
Yeah.
I don't think they realize,
I
I
do
mean,
think they think that.
I don't think that
They're
that's,
emailing their provider.
They're emailing
Right.
their provider.
and they're thinking it's coming directly to me.
I mean, I think if it's a simple question like, what is my dose of
Right.
Claritin, that the nurses would answer on the phone, it's the same thing as if, a patient doesn't call a nurse at the
And I think
practice
it's, and I think it's,
not think we're at all involved. Like,
and I think it's okay to put that barrier up anyway.
And I believe it goes back, I think
Right.
it goes back to the patient as you.
I am,
Sure.
It'll say the nurse.
I am perfectly happy emailing with my patients. I love it when they send me messages, but I don't wanna be doing a Claritin dose. That's a waste of my
I
time.
mean, the thing with the,
So,
yeah.
I think if it is a yes, no, simple question that a nurse would triage routinely day in and day out, they should absolutely have the right to respond
Well,
to that.
especially like if we're not here, like I know I've come in after 4 days and been like, oh, this was such an easy question, could have been answered last week.
Yeah.
But it was addressed to me, so it got
So
sent
then
to me.
forward it
But
on,
I
and
don't-
it's like in your box.
I don't expect them
Yeah.
to do you started me on Ritalin last week.
Oh, no.
That comes right to me and I
Correct,
write
and that should.
Yeah, but sometimes what happens is in a really long email, and then the nurse calls and they spend, it looks like a 15-minute phone conversation, which if I had just seen the message, I would have written back.
I think there are just basic messages.
Yeah, there's a really good, Lester has done, he's a master at this. If it takes more than 2 sentences to answer, that's a visit.
I see that.
That's a visit.
So, but-
15 minutes on the phone.
But that's Lester and that's not necessarily us.
Say again?
So the problem obviously is we all have our individual.
I think they can use their discretion. If this is like, can I give Tylenol before my shots next visit?
Right.
Yeah.
Right. It doesn't necessarily have to wait and come to me.
So,
And I think they're very smart. They know what messages they
Trying to
can
figure
answer.
out what they can respond
Yes.
to and what
Treat
really
it like,
needs to go.
treat it like a call.
But
Just
I
like a
think
phone
it's
call.
certain nurses will answer, certain just, I think they think the policy is to find out who it was addressed to and send it to.
Yeah.
And it might be a quick, hey, but if you see a message addressed, but it's an easy answer and it's something you would
But then
normally
is there a way
triage.
for us
Give
to
them a
also,
call.
one of us to okay the, because they're giving, I mean,
Yeah.
it's just like on a
I would
phone call,
assume
where
it
medical
would
advice has
be the
been
same as a
given
phone
out.
call.
I mean, if they could do it the same way, I think.
Yeah.
They can.
That's what I'm saying.
Well, they have to make it a
Meredith
telephone
is saying they
encounter.
don't see it. You won't.
It's not unless you make it a telephone encounter.
So then they have.
Or they,
So they,
Like, you should
so
be
then
able
you
to
have the
route
right.
On the sending closed workspace, there's a route
There's
at the
route
bottom
to,
there.
route to portal and route to.
But then we only be careful again to route it to somebody who's in the office that
But
day.
that's not when you reply to patient. Not at what? If someone sends you a message and they're replying.
I think you can.
Oh, I can't believe it's gone for good.
Well, another thing too is that me type of thing that can wait 2 days. It's like, like a medical advice was dispensed and nobody saw it that day, which to me seems like a problem. So like, a lot of these are coming like late Wednesday night, I walk into like 3 encounters and we're like, like maybe we're not scheduled for the day, but Abby didn't hear about it the night before when they made the plan to come the following day. So like, to me, that seems like a risky situation. I think that a provider who's there that day needs to look at the encounter. And then if they want to forward it to me, so it's like an FYI, I think this is a good plan, that's not good.
Yeah, I think the nurses, well, I don't know what they know anymore, because there's so many.
We have a lot of new people.
There's so many new people, but, it's always been the theory that if it's something that's just an FYI or something that can wait, isn't urgent, it can sit in your box.
That I totally agree.
Right,
But
if
this
it-
is like
they
a,
need to know what's
kid
urgent,
was
not
having
urgent,
some
but.
problem and booked into my schedule for the next day, and there's no evidence that anybody in the office looked at that encounter at all,
Oh,
except for the
I
nurse.
think this boils down to like clinical intuition.
Yeah.
It does.
Hard
It
to
does.
like suss
It's
this
so
out. Like,
hard.
you have to teach the nurses
Right.
intuition. Like,
Which is
that's
gonna be
hard,
your job.
Okay, which is not okay. I don't, that's like time for so many
I
hours,
know.
but the nurse has, looking at it, has to
has
understand.
to have some
Do I
sense.
send it or do I not?
I agree, I agree.
It's kind of hard.
Yeah.
Like, we can make policies all we want, but the nurse looking at it has to figure it out.
That's the answer. I don't know. That's the answer. How are you doing for time? I'm sorry, I don't have my.
40 minutes.
9:40.
Oh, okay. Real quick, we already met, Alyssa. I just wanted to
Hi,
also.
Alyssa. Hi.
Oh, I'm sorry, some people walked in late.
Somebody was late.
Sorry, I was
Somebody
late.
was late. Alyssa's gonna be starting with us hopefully after the summer, hopefully
Life's a mess today, so sorry.
Yeah. And I think, it wouldn't be a bad idea to maybe just go around and introduce ourselves. So, Adam Strauss, one of our partners.
I'm Susan Holmes, I manage the front desk at the building department.
I'm Marta.
You know me, I'm Carol, the administrator. Cheryl, assistant administrator.
Amanda, nurse manager.
My name is Mike, I'm one of the teachers.
I'm Lisa, I'm one of the teachers.
I'm Jill Fisher. This is not my baby.
It's mine.
I'm Catherine, one of the MPs.
We met.
Yeah, we met. Okay, okay, all right, and there's more, but there's not on here. Just an FYI, I did send a message out, but Annie's totally full, so we're just putting a hold on her for a little while, let her catch up. I'll let you know when she's feeling ready to.
So previously, when we couldn't find anybody, we would, I think some people would send Jessica a message to say, can't get anyone in. So I've been utilizing Danielle.
Danielle.
Is that appropriate?
Yes.
So if we can't get anyone in because Annie's closed,
Yes.
utilizing Danielle, she's gotten people in the last week to other people because I can't.
Yes.
It's full, so
Yes.
just making sure people know to reach out to Danielle to help.
She's talking about
Oh,
Jessica.
okay.
How quickly we forget.
Yes, we do.
She gets people into outside people, you're saying?
Yeah.
Outside people?
Yes, because previously Jessica Matthews had a master list of outside people.
Yeah.
And now
Hopefully Jen,
Danielle has that.
She's got it.
She has
She
all
does.
that.
yes, that is an appropriate use of Danielle's services.
Yes.
Yes.
So right now it doesn't kibosh on her.
Yeah.
And also, is there any behavioral health education that you guys feel like you would like to hear about, or, we could bring someone in, or one of our distinguished providers could give some information on? Is there anything in particular on behavioral health that you'd like to freshen up on, sharpen your knowledge? Not right now. If you do, go ahead.
I would still like a talk on the emotional burden of handling acutely ill behavioral health patients.
From a provider perspective?
From a provider
Type stuff.
perspective.
We need a how to be the therapist talk, because we don't have any training in that.
So there's some really good people that can do that.
That's not for patient, I don't think.
And not gonna go to.
Again, and we're handling suicidal patients on a weekly basis.
Yeah, and I think it's even just like a half day in-service for all of us on all these meds we're now regularly prescribing. My adolescent behavioral health, like, what do you call it? Group,
They would have to
following,
forward
yeah.
Melissa would have to.
It's hard.
Say,
I have a lot. I don't think I noticed it till my students were like,
and I have to say, yes.
right, so you don't notice it, then you know, something else inside. But then sometimes I feel lost. So do you think, so you think a half day, this would not be enough, 2 hours?
So maybe.
Like, let's say we dedicated 2 hours.
this was 2 hours.
Right, that's what I'm saying.
Right, I don't know, I think a half
I
day.
think a half day in
Messages
service.
that are
We could do a 3-day conference too,
Yeah.
but
and then forward them. to-
something.
Find some of that like provider burnout stuff through that.
Emotional, yeah.
Because all the messages
Burnout.
that I just left on my
I
phone.
feel like I did not sign up to be.
So then they kind of
Yeah,
disseminate.
there's a lot.
And so maybe diaper rashes.
Yeah. Thoughts would be good.
Subject messages.
Yeah.
It does look like it's kind of hard. So when you get the message from the family, you can forward it to someone, like the nurses forward it to us because it's gone to the pool. But when you're in the reply to patient, there isn't any other routing. It replies just to the. So if the nurse were to answer the question and say, I'm writing on behalf of Dr. Hyde, when they send it, I wouldn't see it.
Right.
Yeah,
Even
you're
But
not
if it's a
gonna see it.
Tylenol dose, I don't
Not
wanna
gonna
see
be-
it.
You don't wanna see it.
Yeah. If you make
You can make it into a telephone encounter.
then they can.
So in
then
the,
they should be
in
able
the
to-
screen before, so get out of this screen, go back to your patient advice screen.
So,
If you do My Chart Encounter right there,
yeah,
yep, and then do copy original, now you've opened a telephone encounter.
and
So
then it
you-
will show up differently in like actually, cause you know how
Then
you
you
can
can route
sometimes
it.
not see emails unless you.
But then,
uncheck
and then
them.
are we asking, then, I guess the question is though, oh no.
Yeah, but then they
Are we
were-
asking then we're asking them to go ahead and make a call and not
I don't
No.
think
message
you
call?
No,
you
you
can
can-
still reply.
Yeah, you can still
But it
reply
will
to
just
patient.
also pull up like a telephone call that they can route to you, so that you can get it in your inbox.
You can sign off on it.
And you
There's
can-
an area to write reply to patient, and that part will still go automatically. But then
there's
the whole
also
telephone
at the
encounter
bottom, like,
will
it looks just like a
their
telephone
message.
call down low, so we'll say send a closed workspace to, you can put you in there.
And do you want them to just enter it or write on behalf of?
Let's work on this.
Okay.
Yeah, I think it's hard.
Okay.
Yeah.
Alright.
What is the time frame? I've had some My Chart messages where it takes like several days for them to get
Yeah.
to me. And some of them are sort of, I mean, I tell my patients, like, if you need an answer the same day, please call and don't write, but sometimes it's been just a little longer than I would like.
I talked to Steve a little bit about that, like the turnaround time with the My Chart, because they're going right to the pool.
They're all going in the same pool, so now
Who's in charge of that pool? Everybody?
anybody.
Oh, it's the nurse, the clinical nurse pool.
Yeah.
So we have, maybe,
I would imagine the bat nurse of the day handles them.
didn't we used to have
Yeah.
someone?
So, the bat nurse, right?
Yeah, the bat
Those are the ones that kind
nurse.
of handling all the block stuff.
Are they handling everything else?
The back nurse is handling the, pool, isn't it? Okay. The nurse pool?
Yeah, so they handle like, labs, media, any certain things like that. So they take care of those tasks and emergency calls versus
Yeah.
actually
Do
being
they have
on the
enough
phone.
time to do all of that? That's hard to think.
Days are different,
Yeah.
so some days, like, as soon as something hits the basket, it's gone. Like, that's how fast it can
Yeah.
go. And then there's some days where they have to sit in there a little bit because the calls are really high.
Yeah.
And there's just a lot to get done. So there's no day is the same.
Depends.
You know, it's almost,
Yeah, I mean, I guess I don't mind replying to an answer
If they didn't
yesterday.
get potentially critical also. If there's language somehow that these My Chart messages are going to your provider, who will get to them when they can, like,
A couple sick
If we're out of the
emails,
office,
like, they're probably not a
that
priority.
message?
Yeah, that was my question.
What was the question?
If we're out of the office, like on vacation for a week, do they get that message from yesterday urgently?
No, that,
Right? That's just not smart.
Right.
You know, you can't
But then
teach
it-
that.
How
That's
did
just
you
like-
know that? How did
Because
you-
I'm covering his inbox,
Yeah.
but it was sent to Lester. It's not an urgent thing, it has no
Yeah.
business being sent like that, it was
But then I
totally
think in
wrong.
instances like that, this or nurse did this, but if I know, say,
I know, the problem is we're like-
Michelle Connolly did that, then I can go sit with Michelle Connolly and say, why did you do that? What was the?
Yeah.
but I do think just overall basic training on certain things.
this is gonna be an optimization effort.
Right.
And it's gonna be, there's an effort on the PPOC too, there are gonna be like little webinars that are gonna be developed to sort of like.
Not optimization, effort optimization.
What is that?
Never mind. Never mind. Yeah, we're gonna have to.
We're working on that. But so it's coming.
I think it's a.
My chart to look at, we've got the. look at.
Oh, the asthma plan, no, so sorry, I missed that.
Yeah, so I think everybody knows, but when you make the anywhere, that there's not a follow-up on the plan. Feels like, I'm just speaking for him, and I'm not saying it, but I think he feels if the parent is looking at the plan and they can see when they were supposed to come back, if they haven't booked the visit, then that he feels that would trigger them.
Lester.
I'm not sure why there are less asthma visits being, I'm not sure that's the reason.
Well, one of the things is the so if you have a well child check and you're using a smart set, the follow-up is 1 year. So unless you're going back and changing the follow-up, which I'm doing a lot less, I know that I've done a worse job with it, and I'm sure most of us have done a worse job with it because it's templated instead of having to push the button. And there's no place on the asthma plan to put it. So unless you're somehow taking the time to write it in the follow-up, it's not happening. And so it's not, so the nurses are getting messages for refills and they're looking and it says follow-up in 1 year. And I think part of this is the nurses in 1 year. Right? They're all in the behavioral health med.
Yeah.
So we can probably teach them to think more than just follow what we say, not necessarily to listen to us.
Yeah.
So I'm sure they're going down because of that. And
There is
are you guys checking when you get refills? Are you going back into the chart and checking it?
No, but
We're
Mary
not doing
does.
it.
Mary Bailey.
Mary does.
Right, but
Mary
Mary's
does.
going on
She's-
what we say.
Right,
And if
right,
we're
that's
not
the
changing
complaint.
it.
But I find that a lot of times she'll do follow-up, not specified or whatever, if it just says 1 year, because
Yeah.
she knows that it should not be
Right.
1 year, and like, that's it. Mary's like, okay, this kid is on a daily med, so did you really mean that you wanted to
Right.
see back in 1
She
year or
knows
not?
to ask that question.
Yes.
But if we can eliminate
So I also,
that.
I also suspect, and I'll speak for myself,
Mary and Tammy, they're not allowed to.
that this year I haven't cared as much. And so my stable asthmatics, if they're not coming in 6 months, I'm not sure I've really,
They're still stable.
I've really
Obviously, they're gonna come
tried.
in if there's.
That's kind of how I
So-
will say that.
Well, so I think that it has been deprioritized for a variety of reasons,
Yeah.
both systematically.
Yeah.
We were hardly had anywhere to put our.
But
Right.
we
So,
can't, but we
so
also.
I think they're all valid points.
Right, we can't, although, we can't depend, I mean, Mary and Tammy.
Right.
We have to have more
I know.
education.
But I think
Yes.
it's more important to have it in the wrap-up than have to read it all
Yeah.
I would
So
rather
maybe the
have it
action
in
would
the
be
wrap-up.
like, try to, in your wrap-up, have the asthma follow-up.
I mean, that sort of makes the most sense. We have a built-in field
Because
for
that
when you're
asthma
supposed
thing
to
is
follow
pulling
up.
in
So,
really well.
like, free texting it in to a note, I mean, that just means nothing to me, because I'm gonna have no idea when they're due.
The question is it useful
Somebody's
for a
to then
parent
read
to
their
have
whole
it on
entire
there?
asthma plan?
Is it, but not for us,
See the
but for the
follow-up.
family, is it helpful for a family to have the follow-up written down
It is.
on their asthma plan?
At least it's like.
But you can make a dot phrase,
Right,
that's like
Yeah.
follow-up in dot, asterisk, asterisk, asterisk months, and then,
right. That really would be helpful if you guys could.
oh, that's what's in September.
You know, I mean,
They
they
can
just
fix
like,
the asthma plan
Oh,
probably
okay.
in September.
can they just, yeah,
Oh,
put in
yeah,
a,
I want that
like,
in
something,
asthma
that-
plan.
That's September.
and that can just be like something you have to choose as opposed to like free texting.
Right.
Cause I'm gonna be honest, I'm never gonna remember to do this. Like, I am really sorry, but.
We, you're okay.
I'm trying my
Honesty
best.
is the best policy.
But I am not gonna remember to do this, so.
The wrap you won't
Well,
be-
September will be here before you know it, and that.
September really isn't far away.
No, it's not, it's not.
You only have to put up with my crazy asthma plan till July, then I'm going on maternity leave.
I promise
When you come back, guys.
Forget everything.
Right.
Yeah, right? Okay.
Happened last year.
twice before.
All right, guys, thank you so much. Alyssa, again, welcome.
your
Thank you
door
for
code.
coming
Yeah,
today.
thank you for having me.
Thank you. Alyssa, you're at Children's?
Yeah,
Yeah, something else.
Last time I talked to you.